You're listening to the Smart Policy Podcast, a production of the University of Tennessee's Institute for Public Service. Naloxone, access to treatment, housing, employment, educational opportunities. We're used to hearing about the need for these aspects of recovery. But what about community? A place to gather with others, especially those with similar experiences. That's where recovery community centers play a role.
We want recovery support services to be free and accessible to everybody. So we are doing our best to remove any barriers.
That's Dottie Greene. She's the executive director of the first recovery community center in the 8-county region of Northeast Tennessee. She's also a person in long-term recovery and has been providing recovery support since the 80s. And as you might expect, she has seen the field of recovery change significantly in that time.
Back when I first came into the field, there was no training. I mean, we were literally plucked out of AA meetings and put into counseling roles.
Our second guest this month is Bettina Hoeppner, who has joined Dottie to talk about her academic research on recovery community centers, or RCCs. Dr. Hoeppner is an experimental psychologist who focuses on substance use disorder, and she directs the Health Through Flourishing research program. Her work on RCCs highlight how their unique natures make studying them as complex as launching them.
What would RCC directors agree this is a good outcome for the people who walk through our door versus clinicians saying this is an acceptable outcome versus the people who are funding the RCC saying this is what we want to fund and what we're striving for. So trying to build consensus.
In this episode, we discuss the ins and outs of recovery community centers and how they fill crucial gaps in the care continuum, as well as how attitudes towards recovery have changed dramatically over the last decade. I really enjoyed this conversation, and we touch on a lot of other issues, such as the need for community in general in modern America.
Bettina, you go ahead.
Oh, see, I was waiting for you, Dottie. All right.
Rock, paper, scissors.
Here we go. So my name is Bettina Hoeppner. I am an associate professor at Harvard Medical School, and my research takes place at the Massachusetts General Hospital. I'm the director of the Health Through Flourishing program within the psychiatry department of MGH. And I came to recovery research really through the work I was doing with Dr. John Kelly at the Recovery Research Institute, where I learned a lot about mechanisms of change. And at the time, we were looking at AA in particular and how AA conveys benefit or confers benefit to people and really trying to understand that. And in doing this work, we then heard about recovery community centers, and Dr. John Kelly led a project on that where we surveyed RCCs in the New England area. And from there, then we grew into our current interest in them. And through the current project that we have that is funded by NIDA, I've had a chance to really interact with a lot of RCC directors, participants, people who advocate for them, for multiple stakeholders around them. And every time I hear more and see more about recovery community centers, I'm very much inspired and impressed. So I'm very passionate about this research, and which is why I'm continuing to do this work.
I'm Dottie Greene, and most importantly, I'm a person in long-term recovery. I began my recovery journey in 1983, so I've seen a lot of changes in our field. And I'm also an associate professor in the Department of Social Work at East Tennessee State University. And I've been working in the addiction field in some form or fashion for nearly 40 years. And I've done clinical work. I've done, worked in recovery houses. I've, done a little bit of everything. Worked in the prison, worked with Department of Children's Services with women, gender responsive treatment. And I started my journey in 1984 professionally. Back then, and Bettina, I'm sure that you've seen this in your research, back then, the only requirement to be an addiction counselor was that you were a person in recovery. And that was the only training that I had. I did not have any education or training. I came into recovery with a 9th grade education. So it's been really interesting. And I feel like now that I've spent about 20 years in academia developing clinical addiction certificate programs for addiction counselors and running those. But now I feel like I've come full circle in a lot of ways, because now I have a pretty good scientific knowledge of recovery, and I have the practical knowledge, and I was getting ready to retire. A grant opportunity came about about a year and a half, almost 2 years now. And RCCs are, developed and run by people in recovery. And I was like the only one in my university that could probably do this. And, I just felt like the universe was talking to me and just saying, it's not quite time to retire. You got a little more work to do here. So, hence the birth of Johnson City Recovery Center. And I am absolutely having a blast. And now I think I might not even retire. So that's kind of my story.
Dottie, it's interesting. You describe an interesting change in trends, the trajectory of recovery as the only real credential necessary at that time. And now these days, it seems that there is such a push to seek out people in recovery to take up more of these spaces. It seems almost like at the policy level an inverse of what was happening on the ground level. Now the buzz is about, we've got to get some peer recovery specialists, and we need some certified peer recovery specialists in this hospital, and so on and so forth.
Back when I first came into the field, there was no training. I mean, we were literally plucked out of AA meetings and put into counseling roles. And sometimes when I think about what we used to do, because back then the old therapeutic communities were in vogue, and it was really a little before the Minnesota model, the 12-step model really came into being. And there were some pretty harmful practices back then. There were some beautiful practices, I think. And one of the cool, just kind of anecdotal things, there were like me and 4 other of my friends in recovery. And we just kind of followed each other when we changed jobs in the field. And all of us remained in sustained remission for all these years. So I'm talking, 40 and 50 years of long-term recovery. That kind of talks a little bit about the power of the bond of recovery too. But in my career also, I've seen lots of people in recovery not have that kind of success. I had a dear friend who I found overdosed, who had been in the field for many years. So, I've got a lot of stories like that. But what I'm, I guess, so excited about now in the field is the training. We're training peer recovery support specialists, and they're getting some really good, solid training. And I think really helps to equip them. And we've also moved away from that real punitive approach when an addiction professional had a return to use. They would get fired. And I shouldn't speak generally, but I know that in my world, my research was around relapse among recovering addiction professionals. But we have moved to a much more supportive and compassionate approach to professionals when they do experience a return to use. And so it's not closeted the way that it was. Yeah, I'm sorry. I could talk about this stuff forever and ever. So
it's actually a really good segue. You mentioned how there is a change in culture and policy in response to return to use. For example, popped into mind how it has been found repeatedly to be a violation of the Americans with Disabilities Act to take someone off their medication if they're receiving medications for opioid use disorder. Bettina, some of the things Dottie was talking about, I was wondering in your capacity as a researcher, how has this evolved? I understand a lot of your work is around the impact of these changing recovery resources, and especially in terms of accessibility. I was wondering if you could provide a follow-up comment.
Yeah, so you did characterize my research correct. That access to care is a huge interest of mine, and the main motivation behind my program of research, which includes recovery community centers. In terms of the science about how this has evolved, there's very, very little science on recovery support services. And there is even less on the peer recovery support workforce. So we know nothing, very, very little about how people do when they receive training, the places that they are then performing those duties in, and there's a wide variety of them, how that impacts them, how much support they are getting, how long they are able to stay in those jobs. We do know there's a lot of secondary trauma as they're being re-exposed to things that they know and that they've experienced themselves. So we know, like, from talking to people, that all of these issues exist, but empirically, we know nothing about that at present. And that's something that we still desperately need to do, especially given this much larger investment and how much peer recovery support workers have to offer and how much we're increasingly relying on them, understanding how they're actually experiencing that job and that career and how much support they have and how it impacts them is something that's critically important.
I've seen meta-analyses showing that, broadly speaking, the more access you have to the more resources possible, outcomes tend to be generally better. But that's an important point about the lack of, let's say, qualitative research, or at least research on variances in quality. If you don't mind, you've just had a paper accepted for publication. I was looking at that. Some of the results that stuck out to me, for example, residents of areas with RCCs were more likely to be Black, which that's an important gap in access right there, is engaging Black Americans. I did see a less likely to be Asian or American Indian or Alaskan Native, as well as a reduction in chances of being rural, which struck me as interesting. There were some other really crucial findings here, but just broadly speaking, in terms of access there, I would like for you to talk about your paper a little bit.
Yeah, for sure. So I mentioned that we started by doing research with RCCs that were near us in New England. And for this one, our task from NIDA was to build infrastructure to really get multiple stakeholders involved in building the science on recovery community centers. And we wanted to involve not just scientists and clinicians, but we wanted to engage RCC directors, staff, members, people who are involved in the policy making about how to fund RCCs. We wanted to really bring everybody together to kind of understand what the issues are, the most important topics that we need answers to, and to also build consensus about how we should assess something like the outcomes. How do you measure the outcome, a positive outcome for RCCs? We talked about 12-step being very abstinence-based, but the field in addiction is certainly moving away from a pure abstinence model and then agreeing on what would satisfy, what would RCC directors agree this is a good outcome for the people who walk through our door, versus clinicians saying this is an acceptable outcome, versus the people who are funding the RCC saying this is what we want to fund and what we're striving for. So trying to build consensus. That's our goal, and that's why we want to have these conversations with our multi-stakeholder groups. And we thought that an important step would be to actually reach out to all the RCCs that we can find in the nation, beyond just our part of the world, but really within the whole country. So that's how we conducted this survey. And we wanted to just really see what services do they provide, who are they engaging, who are they, where are they? And that was what was behind our survey. We also did ask about outcome measures and what they thought about those. But one of the things that we've also wanted to really look at is where we're located. What communities are they serving? Because so oftentimes we see disparities, racial ethnic disparities about, you mentioned Black Americans not being able to reach resources, not being reached by the treatment community. So we wanted to see, how does that look like for RCCs? And here we found that they successfully engage Black Americans. They also successfully engage young individuals in recovery. So folks who are traditionally underserved, RCCs have the ability, at least according to our survey, to be engaged. And that's an incredible message of hope, and it's inspiring that they're able to do that.
Dottie, I was wondering, in your RCC, I mean, you serve a very rural area, and a lot of people don't realize how diverse Northeast Tennessee can be, too. But I guess I was wondering if I could ask you a bit about how your RCC is doing specifically.
So we've been open officially since January 3rd, 2023. So we're brand new. We're located in Johnson City. And so far we've served about 7,000 people in our groups and events. But those, I see your eyes.
Yeah.
But that's not unique individuals. We've had about 7,000 attend all of our groups and events. And some of those, are unique individuals that have come multiple times. So our best guess is that we've probably served about 900 to 1,000 unique individuals since we've been open. Now, and I say our best guess because one of the fundamental principles for us is that we want recovery support services to be free and accessible to everybody. So we are doing our best to remove any barriers. And one of those barriers are that not everybody wants to sign in and give their information. And we allow them that option. We track our numbers if they're coming, to the groups and all of that. That way we do that. I'll get a good count. But if somebody doesn't want to sign in to RDP, they don't have to. Although, we share that it's really helpful for us to have numbers and be able to show this to our funders. But a lot of people actually choose not to because they've had experiences maybe in professional treatment or in the, criminal justice system or, all of that. So
I was going to say fear of reprisal is just such a
absolutely.
yeah.
And the stigma. I mean, we had somebody yesterday, a great example, somebody who's been in long-term recovery for a number of years and chose, really didn't want to sign in because of his professional standing, and so, it's across the board. And our RCC, we serve people from, that are currently using all the way to people with 40 or 50 years in recovery. And, we have about 20 mutual aid and support groups a week, anywhere from traditional 12-step AANA. We have Wellbriety, Smart Recovery, Mindfulness for Recovery, ACOA, Al-Anon. I mean, we do a little bit of everything. And we're actually doing really well for our first year. We have my projected outcomes. We're probably I would say, doubled that for our first year. And we've gotten a lot of support. The community, we do naloxone distribution. We have an outdoor naloxone box too, where folks can access naloxone on the weekend or after hours. And we have a lot of folks that access it because of the stigma.
Right.
They don't want to come in, and we also have one big social event a month, which is that's probably the most popular thing we do, which is a loads of fun. We have a game night. We've got Super Bowl Sunday this weekend. So 3 TVs. And so y'all come on down if you want to. But our community has been incredibly supportive. We got a startup grant from the Washington County, which is where we are, Washington County Baby Doe Litigation Funds. So that was almost 2 years ago. And we were just blown away that the city council supported us. I mean, it was very impressive. It said a lot for our county government and city government. But yes, I mean, I'm tickled pink at how we're doing, and we don't quite know how we're going to sustain everything just yet. We do offer some peer support specialists, continuing education that brings in a little bit of money and some grants here and there, but we don't have enough yet to feel solid like we're going to be sustained for the long haul. Although we've got some big grants in, but we have a lot of work to do around sustainability.
You say only about 900 or so individuals in your first year. I mean, that's really, really tremendous. So this not one size fits all. This any approach, all recovery type approach seems to be exactly the kind of fit. And it's not just in terms of treatment modalities or expected outcomes. It's also additional supports, like you mentioned, the social determinants of health, transportation, and I've seen other RCCs do clothing drives and food banks and on and on and on. It is this panacea of options and the lowest barrier possible that seems to have the most impact. Bettina, in your research, I see that discussions about medications for opioid use disorder were extremely common, that support for that is extremely common, like well over 3/4, if not 4/5 of all RCCs reported engaging in those conversations and supporting those options. On the whole, it does seem like there is a large support for medication as well as for 12-step modalities. This openness to treatment modality seems to be the key to success. What would you say the same?
I think that's one of the most inspiring parts. Like, I think there's been so many paths that are distinct from each other that didn't live happily and comfortably with each other in the addiction field before, and seeing how in an RCC, which is, it's a community, people come there for the people, right? That there is a setting that allows so many different, diverse pathways to engage with. Some people come for the 12 steps. Some people come for the yoga. Some people come for the mindfulness intervention. Some people come for the navigation to resources. Somebody comes to write a resume. It's all one place, and a variety of people are coming through the doors and are interacting with each other in a way that is welcoming, right? People wouldn't come back if they didn't feel like, even though this is me and this is my path, I feel welcome here. Even if other people choose differently, I can choose this and feel welcome and feel happy to come back. I think that is a really inspiring part of RCCs. And the reason why we highlighted medications in particular in our paper and in our survey is because we wanted, again, to bring together the multiple stakeholder groups. And oftentimes there has been a pushback in 12-step organizations against medications,
Right.
making it difficult for physicians to send their patients, to say, this is, I'm not telling you one thing and they will tell you another thing, and there is an inherent conflict there. So we wanted to see, what is it like in RCCs? Do these boundaries exist there? We know that people have strong opinions one way or another, and having different opinions is great. Just to what degree does the RCC, how does the RCC handle that? And these are the comments we got back about having conversations, being open, it being really a welcoming place. So people who are choosing to use medications for opioid use disorder or other medication-assisted recovery, they can feel welcome and they don't have to hide that. They can find resources, knowledge, other perspectives and experiences that can help them along that path. And that's why we really wanted to highlight that.
And that's exactly what's happening here. I mean, I love that you said that, because really the medical clinics that utilize medication to support recovery, we're like the go-to here, because there is so much friction and controversy. And we have like a MARA group. We're getting ready to start 2 all recovery meetings in March. And one of the things we're known for in the community is that no matter what our meeting is, if it's traditional 12-step, Narcotics Anonymous, everybody's welcome. So we're getting a lot of our referrals from the medication-assisted recovery community, But there's so much fear and stigma. I mean, oh my gosh, it just breaks my heart. I mean, these are folks that need recovery as much as anybody. I mean, their chances, the risk involved with opioid use disorder is enormous. And so we've really worked hard to get that out in our community, that we welcome everybody. Nobody is turned away. And in the community, it's been such a need here, because we still have that, oh my gosh, that, there's a lot of archaic thinking around medication, and just erroneous information that, still kind of that replacing one drug for another mentality is very strong in some of the 12-step corners. But we're opening up. I mean, I've seen a lot of change. We got a lot more to do, but I am seeing some change in attitudes around that.
Seeing people, right? Like, it's one thing to have an idea about something, and it's another thing to know a person and know that they're on a different path and how they're choosing. That personal connection makes all the difference in understanding something more deeply and feel differently about it. I think it goes beyond if you use and how much you use. So I think the idea of reducing substance use as a very important outcome, it has moved the field tremendously, and the studies that show that this is an excellent marker for other improvements downstream has helped a lot. I think where it becomes interesting for defining the outcome for a recovery community center is that the recovery construct isn't just substance use. It is a multidimensional construct that has to do with your mental health, your social environment, that the degree to which your determinants of health, your social determinants of health are met, your living circumstances. So an RCC supports you in all of these dimensions. So if you solely focus on how much they are using, and by not reduce, that's only a piece of that whole recovery journey. It's a journey to help folks with education attainment, with job placement, with well-being, with social connectedness. It's like all of these other things that are the rich milieu that bring people to recovery community centers. It's what they're striving for in recovery. And that needs to be captured, and that needs to be celebrated when those progresses are being made. And that's what I think is really needed in terms of determining, what is the best outcome measure for an RCC, something that really embraces that and captures that and celebrates that.
I'm pulling up some numbers here, looking at the Opioid Abatement Council and its funding for this first round of statewide grants. The number one category by far in terms of applications that applied was recovery support at 37%, followed behind by treatment at 28%. I expected treatment to be 70, 80%. I was really, really surprised to see recovery support, which would include RCCs, housing, a number of other things, be so strongly represented here in the applications.
I'll tell you a little even better, well, not better news, but really good news around that too. I was just in the OAC meeting yesterday. They restructured the funding pie chart, who's getting how much of the funds. Recovery support services were number 2. So they've designated 20% of the funding to go to recovery support service proposals, and then like 30% to treatment. So recovery support is really being recognized and valued.
Yeah, that is a massive shift. And it is good that original percentage that the OAC had pinned on treatment was 40%. And the thinking was that because treatment is so expensive, it would need a significant amount of the money. And there's, of course, still truth to that. Treatment is expensive. But yeah, to shift away, to bolster the funding for recovery support services really does reflect not only...
It's phenomenal.
Yeah, it's really a pleasant surprise. I was wondering if you two could reflect on how these attitudes are changing at these levels.
So I will say that, when we did our survey, we asked the question about how long has your RCC been open? And for more than half of our RCC directors, it's been less than 5 years that they have been in operation. So there's like this tremendous growth in RCCs. And since our survey, we conducted our study for a year trying to track down everybody, and I'm sure we missed many folks. So there's more out there than we know. But there's been many more that have been opening since then. So I can only speak for Massachusetts, where I know the numbers a little more concretely. That we went from I believe it was 8 RCCs in 2004 or 2008, and now we have 39 funded RCCs. So that's a tremendous investment there. And it's not the only state. There's other states that have gone through similarly explosive growth phases in terms of supporting recovery community centers. And why I personally find that really exciting is because many people who might not go into treatment, who might not seek formal treatment, they will walk for the doors of an RCCs and they will say, let me check it out. So we are now reaching through these recovery community centers, folks that haven't had help before, that haven't had support. It's a much wider net that is being cast. It is much more accessible.
It seems to me that really one of the biggest benefits is that engaging space, that space and context wherein people can just have fun, frankly.
Yeah.
I know it sounds silly, but in today's day and age, it's really hard to have fun without some sort of substance being shoved in your face through advertising or really the only places, like some towns, really the only place you can go to have fun is going to be a bar. That can make it very difficult for people in recovery. Dottie, I see you nodding your head. Young people are having this issue, reporting this issue a lot, that there's not enough ways to engage with their community and have fun in places that aren't extremely expensive or or don't involve exposure to some sort of substance. And we've seen at the user level that boredom, lack of loneliness, that lack of engagement with the community is a major reason for not only initiating but continuing use. I mean, is this a model that not only for just recovery spaces, but for communities in general? You know, it's beyond an addiction crisis. We're having a loneliness crisis. I mean, is this something that we're rediscovering? Are these community centers?
I think so. I mean, we've had community centers for hours, and certainly we have elder community centers, and they serve that purpose of reducing loneliness and engaging people. So, and that's a model that's worked, and which is why we have more of them. And I think it's great. And the fact that an RCC isn't just a service place; it's also a place for information sharing. But then the social aspect, a social place to come together and be connected and to engage in rewarding experiences with others who get you and who respect you and who understand you, and then just doing things together is a huge component of that I find incredibly helpful.
It's funny that you said that, because when I describe our RCC to people that don't know anything about recovery community centers, I said, well, think about it as the senior center. That's who we are, but for people in recovery. And people get that.
Right.
I think I might have said this earlier in our conversation, but one of the, I guess, biggest things that we do is really provide that safe, welcoming environment. We have people that come by after work, to hang out, get a cup of coffee. And, you walk in, and most days you're going to hear some laughter when you come in, because it's just, it's really, we just have a blast. And people, all the people that are coming through here, the 900 unique folks, the 7,000 people, for the most part, those are people that have not used drugs or alcohol that day and have stayed alive. So, I mean, that's kind of the bottom line, is that that's a lot of people that, have at least some hope that day, and most of them are coming back. But here is the absolute coolest thing, I think, about what we've done so far, is that by having that presence, we don't require appointments. People can make appointments if they want, but they can just show up anytime they want. The coolest thing is when we have folks that stop by and say, God, I had to come by because I really want to get high. I was getting ready to, go cop, and I remembered y'all were here. We had one guy not long ago say, I was getting ready to go to the ATM, and I just got paid and take out all my money, but I remembered y'all were here. And, that for me is like, okay, we're doing some good work.
So the biggest takeaways, I think, then probably sustainability has to be ascertained, that a sense of autonomy, that grassroots, ground up, recovery-based, lived experience-based component has to be preserved. And
absolutely.
And that one size certainly does not fit all. Okay. Well, I think those are good takeaway messages, though, for folks. Dottie Greene, Bettina Hoeppner, I appreciate you both joining me here today on the Smart Policy Podcast.
Thank you for having us, Jeremy.
For more episodes on in-depth discussions on Tennessee policies related to substance use disorder by a range of local experts, please subscribe to us wherever you get podcasts and visit our website at smart.tennessee.edu. I'm Jeremy Corvillis. Thank you for listening, and see you next month.